to this 27th episode of our Pudukkottai ISA branch, Pudukkottai Budan, a weekly webinar of our branch. And at the outset, I invite our Secretary, Dr. M. Periyasamy, to give the welcome address. Over to Dr. Periyasamy.
Thank you, sir. Respected Academic Chairman of ISA Pudukkottai and Dr. A.L. Minasundram sir, and President Dr. Suresh Kumar sir, President Dr. David, and members of ISA Pudukkottai City branch and delegates, those who are attending this program continuously. I welcome you all, and on behalf of ISA Pudukkottai. Once again, I welcome our ISA City branch as a small branch with members of 22. We are conducting this Pudukkottai online webinar ISA program from March 22 as Pudukkottai Budan. This program is going on every week with continuous effort and support of our Academic Chairman Dr. A.L. Minasundram sir. So at this juncture, I would like to thank our Academic Chairman for his continuous support and hard work for adhering to our ISA Pudukkottai. So already, I have already told from 23rd of March 22nd, we are continuously conducting this program. Start from laryngoscope to last week, we conducted this program, and our national president and state president also facilitated this event with this mechanized facilitation. Today, this week, we are going to have our Dr. S. Ramesh sir, consultant pediatric anesthesiologist, Kanji Kamagodi Child Trust Hospital, Chennai. He's a well-known pediatric anesthesiologist. He's continuously giving so many lectures from national to international and state conferences. His lectures will have big gathering from PGs to consultants. So I welcome Dr. S. Ramesh sir on behalf of ISA Pudukkottai to chair this session. Welcome you, sir. Thank you, sir. And next speakers, we are having three speakers. Dr. Jinan Abdul Rashid, a resident, Government Medical College, Kannur, Kerala. Madam is going to talk about microcuff tracheal tubes. Welcome you, madam. And another speaker, Dr. Sajina, Assistant Professor, Government Medical College, Kannur, Kerala. Madam is going to talk about perioperative fluids in pediatric patients. Welcome me, madam, on behalf of ISA Pudukkottai. Thank you. And next speaker, Madam Dr. Aswati, Senior Resident, Government Medical College, Kannur, Kerala. Madam is going to talk about anesthetic management of tracheoesophageal fistula. Welcome me, madam, on behalf of ISA Pudukkottai on this 27th ISA online webinar program. Once again, this program success is based on our Academic Chairman, Dr. A.L. Minasundram sir. Once again, I would like to thank our Academic Chairman. And this is more important event because Medical Council of Tamil Nadu Medical Council giving credit hours for participants with this online webinar ISA program. For that, if you want credit hours, you have to pay 100 rupees for us. The details are given. You can note it down. Otherwise, I will chat it again in the chat box. The 100 rupees you have to pay in the name to our bank account, and you have to give your identity of this program attendance. and your email ID and your contact number. Those details should given to this sent to this ISA Pudukkottai at yahoo.com email ID. And today we are having three interesting topics. Trucking business, I think, is a very tough topic. We have to share the airway between the surgeons and us. And another one is micro coffee tips. And more important is intravenous fluids. This without intravenous fluids, it is very difficult to give anesthesia for any age group. So I am giving a small poem about that. A man is made of lovely fluids, making the blood to merge then expand. Carrying so many vital minerals, care is given to man and other animals. The fluid spark with an electricity. The heart pumps with tonicity after that. Our souls depends mainly on this solution in severe and critical condition. Wrinkled and dry skin and cloudy memory respond well after rapid infusion and perfusion. Common spirit always grows its wings. The cool fluids warm up the core of core to back his kings. With this, I thank you all and thank our president for giving this opportunity. Thank you very much. Over to President.
Okay. Thank you, Dr. Periyasamy. Dear Secretary, our Treasurer, Dr. David, respected Academic Chairman and Director of Medical Education, Dr. A.L.M. Sir, members of Pudukkottai ISA branch, and respected Dr. S. Ramesh from Child Trust Hospital, Chennai, who has consented to be our chairperson of today's CME. Respected Dr. Sajina, Assistant Professor, Government Medical College, Kannur, Kerala, Senior Assistant Dr. Aswati, and Resident Dr. Jinan Abdul Rashid, delegates and senior anesthesiologists who have come here to watch the CME. For everybody, on behalf of our ISA Pudukkottai, once again I welcome you all as the President of ISA Pudukkottai. Under the able guidance of our A.L.M. Sir, we are able to run the show continuously, and today is this 27th week, and we are able to cater so many topics which are useful for the postgraduates, practicing anesthesiologists, and at this juncture, we are covering the pediatric anesthesia, and today's CME is very important because we have our chairperson, a doyen of pediatric anesthesia, Dr. S. Ramesh, whom I am following from since 95. Doctor, I want to tell one or two sentences about Dr. Ramesh sir, because I admire his anesthesia skills, his humor attitudes in conferences, and particularly I admire him for one feature. He has visited so many professors of anesthesia who written books, anesthesia books in the abroad. He had made a point that he lived some days with them, he practiced with them, he discussed with them, which I think nobody had done in India. Thank you, sir, for coming here, for giving us this opportunity to be a chairperson. And I am very happy that Government Medical College, Kannur, Kerala has assistant professors and resident and senior resident have come here to give the topics which we often have some doubts whether to use cuff or not, what fluid to start in the pediatric setup, and they will definitely give a light for these topics. And once again I request all the people assembled here to make use of this program today as well as in future. And these topics are also can be seen in the YouTube also. Thank you. I now hand over the proceedings to our academic chairman, Professor Dr. A.L. Meenakshi Sundaram sir. Over to Dr. A.L. Thank you.
Thanks, Dr. Suresh Kumar, President ISA, Dr. Periswamy, Secretary, and Dr. David, Treasurer. The faculty today, Dr. Ramesh, Dr. Zinan, Dr. Ashwati, Dr. Sajina, and the person who has introduced this team, Dr. Rahul Anand from Kannur Medical College, and all the delegates. It is really a good evening for the simple reason, a legend in pediatric anesthesia. That is, I used to say, a geriatrician in pediatric anesthesia. Dr. Ramesh is chairing the session. At the outset, the beginner, Dr. Zinan, the junior resident from Kannur Medical College. She is interested in pediatric anesthesia and regional anesthesia. And Dr. Rahul Anand has correctly selected that postgraduate microcuff tracheal tubes. She is going to deliver a lecture. And Dr. Sajina, that assistant professor, she has done her UG in Coimbatore Medical College and a PG in Nagpur Medical College, and she is working as an assistant professor in Kannur Medical College. And Dr. Ashwati, she is going to deliver a lecture on anesthetic management of tracheoesophageal fistula. She is also an assistant professor in Kannur Medical College. And these three were enthusiastic about pediatric anesthesia. They wanted to know who is the chairperson. But I kept the cards close to my chest because the moment I say it is Dr. Ramesh, then they will be afraid. But I have convinced them, see, Dr. Ramesh, such a experienced anesthesiologist. And as far as my knowledge goes, he's the only one in the field of pediatric anesthesia for nearly 35 years. The day when he has graduated, he is working in a pediatric anesthesiology department, and his experience is spreading to 3 decades, but he always looks like a 30-year-old man. That is the specialty of Dr. S. Ramesh. See, he is more experienced, but when compared to ourselves, our experience in pediatric anesthesia is just like a baby. But completely, he has gained experience in pediatric anesthesia, and whatever disease you say, whatever clinical phenomena you say, he will be having a video for that. He will be having a photograph for that. And as Dr. Suresh pointed out, he has traveled the length and breadth of this entire world. And he is having a photograph with all legends in pediatric anesthesia. I have seen his photograph with Frederick A. Berry, whose pediatric textbook is so popular. He always is seen with the legends in pediatric anesthesiology throughout the world, especially the white-skinned individuals. But he is such a down-to-earth person. He always keeps a smiling face. So these faculty, these 3 beginners, they are fortunate to have the chairmanship of Dr. S. Ramesh, who can cover the length and breadth of pediatric anesthesia subject. And he has talked at least 100 times about tracheoesophageal fistula. He would have delivered lectures in perioperative fluid balance 100 times. This microcuff tubes, even now he has talked. And Pudukkottai Budan has made it a point. We will introduce youngsters under the able guidance of seniors. That's what we are doing. And I personally thank Dr. Ramesh. Whenever he delivers a lecture, I make it a point to attend. Whatever may be my schedule, even if I miss, I'll say the recorded version. See, the practical way, the way in which he demonstrates, that is astonishing. And you can see his expertise in covering the entire area of pediatrics. Now I hand over the proceedings to Dr. Ramesh, chairperson. Thank you, sir.
Good evening. Are you able to hear me?
Yes, sir.
Okay. Thank you so much. I am really humbled by all these introductions and it's really proud. I just want to clarify a couple of things. like two things. One is by Suresh Kumar, that he has traveled and he has mixed with one, he has got photographs with everybody. And other one, the comment by A.L. Meenakshi Sundaram, he is always with the white people. Not that it's a white people. I'll tell you very, very important reasons for all the people. Why I do all these things. This is not, one is not really to show off that I have traveled or I have been with the people. I'll tell the reasons. Number one, when I took up pediatric anesthesia in 1986, I think there are one or two persons who are doing. One is Dr. Pudukkottai, who was a very senior person who was doing pediatric anesthesia. He only introduced to this particular hospital, he will grow with the institution, and that's what he promised, but I have grown with this institution. The second person, probably Dr. Nagaswamy, is also it is a pediatric anesthesia. He was instrumental. But we didn't have a proper training that a pediatric anesthesia in 1985. Now we have a DM, we have a fellowships and all these things. But when I took it up as a pediatric anesthetist, please, this is for the youngsters, that I thought some of them I got into trouble, and I was doing pediatric neuroanesthesia like craniostenosis, which I was not doing when I was during training, and I was doing regional blocks, which I am not sure whether I am doing right or wrong. So I thought I should not unnecessarily get into it. That's why instead of buying big cars and big phones, and those days I just bought a smaller cars, and then the remaining money I traveled to different places just to learn, not to take a photographs with them. But when you go there and go meet the person, and you see like Frederick Berry, who has written a book, and you take a photograph, and it's really, everybody will not be able opportunity to see him personally. So I want to take a photograph to tell them that I met all these people. So it's a really pride. The second is that whenever I read an article, and that article is first author is probably like anybody like a Fisher or somebody who's doing it, and I take a picture. When I'm reading the article, I remember, oh, this person is the one who has written the article. So it's a really a memory of all these people to be along this, and people who have not seen, probably even if you are Dr. Pudukkottais photograph, many would have seen. I have taken a picture, and he is the one who trained me. So I think that's the important thing, to show the people, our gurus who have trained me. So by the traveling, you learn a lot of things. And second important thing is, you also learn not good things, you will also learn bad things. Many tube slips in America, many of the things, they don't get a line for 1 hour, 2 hours for a pediatric. We think in America they get everything all right, they don't get problem, they get the same problem. So when you come back, you also feel that, one lung ventilation, enterobronchial intubation, all these things, what's happening here, you also happens here. So you get a confidence you are doing the right thing. So that is the main thing, not really to show off, but I don't want to preach wrong things for the youngsters. That's one of the reasons I am traveling. And whenever I am traveling, I travel only to and fro. The remaining, I always beg some relatives or some friends, please give some corner place, I will just sleep there. So the remaining food, even every operation theatre in US and or UK, there will be a lot of fruits, bread and bun. That's how I survive in that particular place, and take a rice cooker and do it. I do a very economically. People think I have a lot of money, I am traveling here and there holiday. No, I just do all these things on my own. I cook. Very youngsters, you can do economically and you can learn. That's how I learn, not because I just have to show off, but I am happy to see all these things, because I can now, if I talk to the people, youngsters, I will not, because I remember 1985, whenever White comes and gives a talk, everybody runs there, and as if he is going to give the very good talk. I think that is not true. You can also, your own people from India who are practical, they do a lot of work, and you can learn something. I think that's one of the reasons which I am doing. Even now I am learning. And for people, not that I go to the white people only take a picture. Even in India, I go to any of the places, when I am teaching it, if they are guru, we take some pictures. A lot of people, I know hundreds of people are faculty who are excellent faculty in India right now. So that is one of the reasons. But before I talk, I just want to give a small information which is really very good. Dr. Frederick Berry, I think intravenous fluids is a Berry's fluids. Berry means intravenous fluids, and Berry's formula. All these things are very well known. You must have visited at least 6 or 7 times to India, many times, but he died day before yesterday. So he died day before yesterday, and I got the message, and it is still there, and I am really very sad that we have mingled with them in US. He has come back to even Chennai ISACON and a lot of places he had come, even in Stella Maris College in 1990 conference he had come, Chandigarh, and we lost. I think it's Kester Brown and Frederick Berry. They are the top people in Australia, and both we have lost right now. And probably third is Pudukkottai. They are all the doyens of pediatric anesthesia. We don't see a people who talk so practically. Thank you, Meenakshi Sundaram. I just want to giving my time to for this. I'll definitely, and all the three people contacted me and tell me, is this all right? This is all the PowerPoint. I told you, do whatever you like. That's okay. Nobody can. So this is a postgraduate, mainly on postgraduate teaching. So it will be like a very nicely they have written. They have taken a lot of trouble and they have written it. I'm sure they'll be able to give the proper lecture. And I just have to give that any small thing. I'll just give the comments. Thank you, Meenakshi. And one thing I want to tell you, I am part of Tanjavur Medical College, and Tanjavur Medical College was really given me all this opportunity. I can't forget two people, Dr. Kishore and Thyagesan, who took third year anesthesia first class. Believe me, I have got the class by Kishore for anesthesia at that particular time. Still my notes is with me. That's the first class I take even for the resident of anesthesia right now. So this is somewhere in 1974, about 45 years, the notes of Dr. Kishore is still with me. So I think it's a great honor to with Kishore as well as with the Tyagarajan, with the Dr. Thyagesan, and both of them is no more if I'm not wrong. So with that, I think we can allow the three people to give the lectures, please. Thank you. The first person is going to talk on cuff tubes in children. You can share the screen. Jinan, yeah.
Am I audible?
Yeah.
Respected teachers and dear friends, a very good evening to one and all. Today I will be discussing on the topic microcuff tubes. Before starting on the topic proper, I would like to discuss few words about uncuffed and the traditional cuff tubes. So, traditionally, uncuffed endotracheal tubes were preferred in children up to 8 to 10 years of age. Lack of cuff allows for a greater internal diameter and thus reduces resistance and work of breathing. Cuffed endotracheal tubes might cause mucosal injury with an increased incidence of subglottic stenosis and post-extubation growth. This is a comparison between the adult and the pediatric airway. Where we can see that the adult airway is more cylindrical and where the vocal cords are the narrowest part, and the pediatric airway, which is funnel shaped with cricoid ring the narrowest part. This notion has been that the pediatric airway is cylindrical in shape, funnel in shape, has been disproven by anatomical measurement using MRI. So nowadays the pediatric larynx is elliptical with a transverse diameter less than the anteroposterior diameter. The cricoid ring remains functionally the narrowest portion of the airway, and pediatric airway is more cylindrical like in adults. So uncuffed endotracheal tubes. The advantages of the uncuffed endotracheal tubes are, here we can use a larger internal diameter and this allows easier suctioning and pulmonary toileting, and it can be also used for as a bronchial blocker. And the problems with the uncuffed endotracheal tubes are the anatomical variation due to the elliptical shape of the pediatric airway, and uncuffed endotracheal tubes that ablates the airway leak exert more pressure on the lateral walls of the trachea.
Dr. Jinan,
Yes, sir.
sorry to disturb you.
Okay.
Your voice is not loud enough to hear. We are not having hard of hearing, but you have to increase a little bit your decibel.
Okay, sir. Should I start again?
Yeah, you start again. But in you can,
Good evening, one and all. Today I will be discussing on the topic microcuff tubes. Before starting on the topic proper, I would like to discuss few words about uncuffed and the traditional cuff tubes.
சொல்லுமா.
Traditionally, uncuffed endotracheal tubes were preferred in children up to 8 to 10 years of age.
சரி சரி அனுப்பிச்சு விட்டுருங்க.
Lack of cuff allows for a greater internal diameter, and this reduces resistance and work of breathing. Cuffed
நாளை
endotracheal
வராங்க.
may cause mucosal injury with an increased
இது
incidence of
பாடி
subglottal
மாற்றி போச்சா?
and post-extubation croup. This is a comparison between the adult and the pediatric airway. Here we can see that the adult airway is more cylindrical and the vocal cord of the narrowest part, and the pediatric airway is funnel shaped.
என்னாச்சு?
The trichord ring the narrowest part. But nowadays, this notion has been disposed in a purely static anatomical measurement using MRI. We have found out that the pediatric larynx is elliptical with a transverse diameter less than the anteroposterior diameter, but the trichord ring remains functionally the narrowest portion of the airway, and the pediatric airway is found to be more cylindrical like in adults. Coming to uncuffed endotracheal tubes, the advantages include we can introduce larger internal diameter tube, and this allows easier suctioning and pulmonary toileting, and this can also be used as a bronchial blocker. And the problems we face with the uncuffed endotracheal tube include anatomical variation due to the elliptical shape of the pediatric airway. An uncuffed endotracheal tube that ablates the airway leak exert more pressure on the lateral walls of the trachea and the larynx. And the other problem is the endotracheal tube with large leak, that is too small size of a tube. Here there is the tidal volume targeted ventilation becomes inaccurate. And the other problem is endotracheal tube which are too tight. This can cause airway damage in children. The major problem with the uncuffed endotracheal tube is the endotracheal tube leak. By minimizing this endotracheal tube leak, this can provide efficient ventilation, accurate end-tidal gas monitoring, reliable respiratory monitoring, and this also reduces the risk of pulmonary aspiration. Coming on to traditional cuffed endotracheal tubes, the advantages include this allows adequate sealing of the airway, and this allows lower fresh gas flows, also allowing measurement of the pressure exerted on the tracheal mucosa. The disadvantages include airway injury. Since the traditional cuff tube have too long cuff, this can also lead to airway injury, too high cuff positions, absent or unreliable depth marks, and no reliable size recommendation. The microcuff endotracheal tube have a HPLP cuff. They are made of ultra thin, that is a 10 micrometer polyurethane inflatable cuff. There is no Murphy eye, and it has a short distally placed cuff, which is there is appropriate intubation depth mark, avoids the formation of the longitudinal folds and channels. Puncture strength is almost double. Burst pressure is more than doubled. This is a microcuff endotracheal tube, so we can see that there is no Murphy eye, and there is appropriate intubation depth marks, and the cuff is also short and distally placed. When we compare to the traditional tubes, we can see that these have a depth mark, and there is short cylindrical cuff which is near the tracheal tube, and this reduces the risk of endobronchial intubation. The size start from 3 millimeter, which can be used for term babies more than 3 kilogram, and the largest size available are 10 millimeter, which can be used for adults. In insertion of a microcuff endotracheal tubes, correct tube size will be usually smaller than an uncuffed tube. 0.5 millimeter internal diameter less than the modified Coles formula is used when compared to an uncuffed tube. This is inserted till the black line at the level of vocal cord, and all 4 graded lines are seen above it. We have to inflate the cuff gradually with a 2 ml syringe until no audible leak when ventilated at a tip of less than 20 centimeter water. And we have to attach the cuff manometer with a 3-way tab and 2 ml syringe. Open the tab to the endotracheal tube cuff and measure the pressure. Here we can see the manometer attached, and this is a 3-way tab. Ideal pressure for microcuff is 5 to 15 centimeter water. If pressure is more than 20 centimeter water, we have to remove air using a syringe. If a cuff pressure more than 20 centimeter water is needed to ablate airly, it may be due to endotracheal tube and its cuff, which are too small, or it is too high in the larynx. Monitoring post-insertion. Cuff pressure monitoring should be done every 6 hours. Pressure should be kept below 15 centimeter water. If leak cannot be abolished by inflation of the cuff to the correct pressures, we have to check the position of the tube. Advantages of the microcuff endotracheal tube. This reduces the endotracheal tube leak, and this allows improved ventilation, reduce the chances of re-intubation, smaller endotracheal tube through the delicate cricoid. This reduces the ventilator-associated pneumonia, allows lower gas flow rates, and reduce airway damage. The disadvantages of the microcuff tubes are mainly the price, which is 3 times more than a traditional cuff tube. Endotracheal tube may get blocked, and then absence of the Murphy eye. Smaller internal diameter increases the resistance, and inappropriate size when used can cause airway damage. The microcuff tubes offer many benefits for routine use in pediatric airway management. And because of the high cost, we have to reserve it for lung surgeries that demand isolation, post-operative prolonged ventilation, pediatric intensive care units, and laparoscopy of full stomach. To conclude, the microcuff endotracheal tubes have many benefits for routine use, and their usage requires selection of appropriate size tracheal tube and cuff pressure monitoring. The extra expense due to the use of the microcuff tubes can be overcome by decreasing the rate of tracheal reintubation with different size of uncuffed endotracheal tubes. The use of microcuff tubes in small children provides a reliably sealed airway at pressures of less than 20 centimeters of water, and reduces the tracheal tube exchange rate with comparable risk of post-extubation stridor. Thank you.
Dr. Meenakshi, who is going to talk next?
Sir, it's me
Dr.
actually.
Sajina.
Yes, sir.
Yes, Dr. Sajina, yes, please.
Okay, sir. Good evening, everyone. Firstly, I will like to thank Dr. Meenakshi Sundaram sir and ISA Pudukkottai branch for giving me this opportunity, and also our Dr. Rahul sir from our ISA Kannur president to introduce me to this Pudukkottai Budan. Hope I am audible to everyone. Now, the topic today is perioperative fluid therapy in pediatric patients. So, the fluid management has always been a topic of debate, be it in adult or pediatric population. So, even in adult patients, we have to yet come to a consensus. So, pediatric population, it is much difficult. So why so? Because in pediatrics, we are dealing with a heterogeneous population. By heterogeneous population, what I mean is they come in all size and shape. That is, there are preterm infants, there are sick preterm infants, then term neonates, sick term neonates, then a healthy child or a sick malnourished child with other comorbidities. So all these children have different physiology and pathology. Also, the perioperative need depends on the surgery per se. Also, the complications of fluid therapy are there. If we overdo it or we underdo it, there can be hypovolemia, hypervolemia, electrolyte abnormalities, neurological complications, hypoglycemia, hyperglycemia. So, all this makes the perioperative fluid management a real challenge for most of the anesthetists. Now, what is our objective of a perioperative fluid therapy? That is to achieve homeostasis. What is that? That is normal physiological state throughout the perioperative period. So we have to maintain a normal extracellular fluid volume, normal blood volume, normal tissue perfusion, normal metabolic function, normal electrolyte and acid-base status. So first let's see what are the physiological considerations that makes the pediatric population different from the adult. So they have a higher metabolic rate, they have a higher body surface area to weight ratio and faster respiration. So all these things makes the insensible water loss mainly from the extracellular fluid compartment. That's a loss of all this. So mainly in preterm infants, the body surface area to weight ratio is so high that they have this insensible water loss. Also, the GFR reached the adult level only by 2 years of age. Why so? Because there is decreased capillary surface area, lower systemic arterial pressure, and there is a high renal vascular resistance. The another main important thing is the body fluid composition. So in fetal, the total body water is around 90%. The ECF, extracellular fluid is 65%. Term, it is 80%. ECF is 45%. Less than 6 months, 75%, 40%. More than 6 months, the total body water is 60% and ECF is around 20%. So we can see in this graph that only by the age of 1 to 2, the intracellular fluid volume rises to 40%, extracellular fluid goes down to 20%. Now blood volume. Now blood volume is different for different age group. Why is it important? To calculate the maximum allowable blood loss intraoperatively. So in preterm neonate, it is 100 ml per kg, term 90. Infants and children, it is between 70 to 80. Again, the hemoglobin levels. Why is important? To calculate the maximum allowable blood loss. So at birth, the amount is very high, that is around 116 milligram per deciliter. But this maximum has the hemoglobin F. Hemoglobin F, it shifts the ODC curve to the left. Again, by 2 to 3 months of age, it drops to 9 to 11 milligram per deciliter. This is also called as the physiological anemia of infancy. But again, here, it's mainly the hemoglobin A. So the ODC curve is shifted to the right. So it's not of much concern. And only later in the childhood, it reaches to 12 to 14 milligram per deciliter. Now, before we'll just see some historical aspects of this fluid requirement. So in 1957, Holiday and Cigar gave this wonderful formula of 4-2-1 rule, which is still in use for the calculation of the maintenance fluid. The concept behind this was that 1 ml of water is required to metabolize 1 kilocalories. Also, they calculated the electrolyte composition of sodium and potassium, keeping in mind the breast milk and the cow's milk. So you are all well versed with the 4-2-1 and its calculation as shown in the tabular column. Then in 1975, Ferment et al., they further took it to the another step, that is, they calculated for the deficit period also. That is, maintenance was calculated using the 4-2-1, and the hours of NPO status was calculated by multiplying it by the hours of NPO. So the half of this volume was replaced to the first hour of surgery and the following half over the next 2 hours. Then Berry et al. In 1985, he simplified it further by suggesting to give a bolus basic salt solution to a healthy child. If the child is less than 3 years, give 25 ml per kg for the first hour of surgery. Child is more than 4 years of age, he should receive 15 ml per kg. Now coming to the main perioperative fluid management talk. So we can divide it as preoperative, intraoperative, postoperative. Now in preoperative, again, the patient will come for elective procedure and emergency procedure. Elective procedure, we have the luxury to keep the patient NPO, and meanwhile, we can attain the normovolumic status. But in emergency procedure, the child has a pre-condition comorbidity, which can be either hypovolemia or dehydration. So we have to take care of that. And the fluid which we give here is called the resuscitation fluid. So if a patient comes with hypovolemia, like accidents, trauma, the main loss is from the intravascular space. So we have to give a rapid correction using boluses of 10 to 20 ml per kg isotonic fluid Maximum you can go up to 40 ml per kg to maintain a normovolemia. But if it exceeds that or the hematocrit is less than 25, you can consider giving blood. Now, dehydration. So there are some clinical parameters and symptoms which can help you assess the dehydration of the child pre-operatively. That is mild, moderate, severe, or shock. So this table shows same. In this, we can see if there is 1% of dehydration, it is equivalent to 10 ml of fluid per 10 ml per kg of fluid loss. So if a 10 kg child has a 5% of dehydration, so there is a deficit of 500 ml of fluid, which we have to give pre-operatively prior taking this child for surgery. Now, how will we rehydrate these patients? So this water loss has basically happened from the total body, extracellular fluid mainly, for a dehydrated patient. So preferably you can go for a slow correction, oral route, if tolerated and you have time. So previously what they said, if a kid with dehydration has gone into hypovolemia, you can use the rapid correction technique of giving 60 to 100 ml per kg for first 2 hours and then go for a slower correction over 24 to 72 hours with isotonic fluids. Later, recently, they are suggesting to give a glucose-free crystalloid containing sodium around 131 to 154 in a dose of 20 ml per kg in 10 minutes in children and 10 ml per kg over 10 minutes in neonates for a period of maximum of 40 to 60 ml. Now, plasma sodiums have to be measured every 6th hourly during this. Also, the rapid correction with hypertonic fluids, if you are giving, they can lead to hyponatremia. So you always have to measure the plasma sodium levels. Now, after giving the rehydrated solutions, rehydration, how will you assess this? So it will obviously lower the heart rate, bring the blood pressure to a normal value, increase the tissue perfusion. You can see that by assessing the capillary refill time, there will be a better urine output, and obviously the sensorium will improve. The child will be more alert. Now, if the child has come for an elective procedure, so now the NPO guidelines have changed so much because now the consent is to give preoperative clear fluids up to 2 hours. In that also, Indian Society of Anesthesiologists has suggested that if you are giving less than 3 ml per kg of water, it can be given up until 1 hour prior to the surgery. So obviously this brings a better outcome both for the child, reduces the risk of post-operative nausea, vomiting, and also it's better for the baby and parents. So this is a fasting guidelines. So clear fluids, water, apple juices are there 1 to 2 hours, breast milk for 4 hours, light meals 6 hours, and heavy solids for 8 hours. Now, intraoperative fluid replacement. So it can be divided into the replacement of existing deficit if not done early, and maintenance requirements, that is giving sugar, that's dextrose, volume, water, and electrolytes, and the replacement of any ongoing loss. That is mainly we are talking about the third space loss and the blood loss. So maintenance fluid, there have been guidelines given by the Association of Pediatric Anesthetists of Great Britain. The nice guidelines are there, and also Association of Scientific Medical Society in Germany. What this APA and NICE recommend maintenance of isotonic fluids based on the holiday cigar formula itself. But the New Year, which is currently very common among us, is the German, which we are following. That is the German guidelines. They have suggested giving a balanced electrolyte solution with 1 to 2.5% of dextrose at a rate of 10 ml per kg per hour initially, and then you can adjust according to the requirement. The rate can be adjusted later during intraoperative period. Now coming to the replacement fluid. So again, third space loss, it's again a much debatable topic. This loss is mainly from the extracellular fluid to the tissues during the surgery. It can range from 1 ml per kg per hour to maximum of 50 ml per kg per hour. So how much it is for any mild surgery or superficial surgery? It is 2 ml per kg per hour. Thoracotomy or moderate surgery, you can go up to 4 to 7 ml per kg per hour. Abdominal surgeries, 10 to 20 ml per kg per hour. Laparoscopic surgeries, it is much less. But if a patient has come for ischiotomy for burns or a neonatal for a necrotizing enterocolitis, then the deficit, the third space loss, you have to calculate up to 50 ml per kg per hour. So now NICE guidelines have suggested to give isotonic fluids only, but they haven't mentioned any rate. Again, these German guidelines have suggested giving 10 to 20 ml per kg of balanced salt solution without glucose until you get the desired effects. Now, these fluids should always be accurately calibrated and given. You can use a burette set or infusion pumps. The infusion pumps are more accurate. Now, Ruschel et al. And in the book of Frederick Friedman Anesthesia, they have been given the definition of ideal fluid. So what is an ideal fluid? Ideal fluid, they have no side effects, being hematological, acid-based, or immunomodulating. It is compatible with other pharmacological drugs which we give intraoperative. It is affordable, available, and it has a longer shelf half-life. But no IV fluids meeting all these criteria is available with us right now. So we'll just see the 3 types of IV fluids available. That is isotonic crystalloid solution, hypertonic crystalloid solution, hypertonic. So this tonicity is mainly determined by the sodium concentration. Okay. So in isotonic fluid, the sodium concentration is between 130 to 150 milliequivalent. If it's more than 150, you take it as a hypertonic crystalloid solution. Less than 130, it is a hypertonic. So in isotonic, when you give isotonic solution, there is no net osmotic diuresis from intracellular to interstitial compartment. Hypertonic, there is the osmotic diuresis from intracellular to interstitial. In hypertonic, it's from interstitial to intracellular. And these will be the effects. That is, cell is shrink here. In isotonic solution, just no osmotic diuresis. And hypertonic solution, there is swelling of an edema of the cell. So again, this hypertonic fluids. So Holiday and Cigar has advocated giving this hypertonic fluid. That is 5% dextrose with the hypertonic fluid. So what happens intraoperatively? There are non-osmotic stimuli for ADH, that is stress, pain, then PONV, any sort of mild dehydration. It all stimulates the ADH. So there is water retention. There is added to that. If you are giving a hypertonic fluid, there will be further hyponatremia. So Hashim et al. He did a meta-analysis considering all the RCTs, and they have demonstrated that giving an isotonic IV maintenance fluid with sodium concentration similar to that of plasma reduces the risk of hyponatremia when compared to the hypotonic IV. So as of now, the fluid of choice is isotonic fluids and not hypertonic fluids. So when you are giving a hypertonic, not hypertonic, when you are giving any fluid therapy, you are always to look for the signs of hyponatremia. So these are the signs of hyponatremia, and if you come across them, you have to always treat the hyponatremia for the better outcome, or there can be even a coma, death, or respiratory arrest. Now, what about dextrose? So both hypoglycemia and hyperglycemia cause neuronal injuries. So recently it is said that in a otherwise healthy child, the hypoglycemia is never a problem, even if the glucose is omitted from the perioperative IV fluids. Why is this? Because the anesthesia and operative stress itself evokes the physiological response that increases the serum glucose level. That is one thing. And the other thing is the diurnal variation of the steroid. So with that, the glucose level also increases. So for elective surgeries, mainly in morning hours, the serum glucose level won't be low. Okay. So now again, the APA and European consensus statement has given, and they have recommended giving isotonic fluids with lower glucose concentration of 1 to 2.5% to maintain an acceptable blood glucose levels. But again, there are children categories of children who are at risk of hypoglycemia, and they need additional dextrose infusions. Who are they? They are preterm neonates less than 48 hours, neonates receiving TP and hyperalimentation, liver failure, mitochondrial diseases, and endocrinopathies below third percentile of weight. And if there is an external regional block you have given, the evoked response won't be there. And if it's there, and the child is going for a prolonged surgery. Now, let's see the composition of some commonly used, routinely used crystallized solutions. So, ringer lactate. The ringer lactate, the osmolarity is around 273, but as you see, the sodium content is 130, it makes it slightly hypertonic. Again, normal saline, but it's good to go. Then again, normal saline, here the osmolarity is 308, but the chloride content, you can see it is way high, that is 154. So there is always risk of hyperchloremic metabolic acidosis. But for a child who has come with nausea, vomiting, and the diagnosis has been pyrolytic stenosis, in that condition, the child will be hypochloremic metabolic alkalosis. So in that case, this normal saline is the fluid of choice. Then for the last 6-7 years, Plasmolite is a routinely used fluid. It is actually plasma minus plasma proteins. So here the osmolarity is 294, and everything else, the chloride and sodium, everything is equivalent to our plasma levels. Also added advantage is here the buffer is not lactate but acetate and gluconate. So if a child with septicemia, septic shock, it is very easy to monitor the lactate levels. Also, this balanced salt solutions, as we saw, isotonic solutions are 0.9% normal saline, ringer lactate, Plasmolite. Normal saline, it is cheap and readily available. Again, there are demerits: hyperchloremic metabolic acidosis, hyperkalemia, afferent arterial construction of the glomerulus, AKI. These are all theoretical, but we have to keep them in our mind. In between ringer lactate and Plasmolite, this Plasmolite acetate, it metabolizes faster, it is independent of hepatic function, there is less oxygen consumption, and it doesn't interfere with the diagnostic use of the lactate. So any fluid, IV fluid, it should, what is an ideal IV fluid we will have? That is isotonic and isoosmolar. Osmolarity between 280 to 300. Now we have given everything, we have to monitor. So what are the monitoring parameters? There are static parameters and there are dynamic parameters. So the static parameters that are good for if the surgery is a minimal mild surgery, but if there's a major surgery, you have definitely to go for this dynamic parameters. Now, whether the child is fluid responsive or not. So in adult, this passive leg rise test is there. So we rise the leg for 45%, we elevate the legs for 45%, and we see there is an increase in stroke volume and the BP rise. In such cases, we give bolus fluid challenge. But in pediatric, this test is not of much use. Why? Because their lower half of the body is much smaller and it doesn't contain adequate blood volume as compared to that of adults. So there is another test, that is the liver compression test. Not liver compression test, liver compression. So what is it that when you give pressure to the right hypochondrium, the blood volume is channeled from the splanchnic circulation into the central volume. So there will be an increase in blood pressure, and you know the child will be fluid responsive, so you can give further fluid. So this is a Frank Starling curve, this cardiac output preload. So if the child comes in this area, that is the plateau phase, it means when you give fluid, the child will respond to that. And if the child won't respond to that, so because it has come to the plateau, but if it's in the steeper part of this Frank Starling curve, that means when you give fluid, the child will be responsive to that, because when you give this compression, there will be wild fluctuation in the arterial BP. So this has come in the Korean Journal of Anesthesiology in 2019. So now post-operative fluid management. So okay, the surgery is over. Now if it's a minor surgery, you can quickly resume the oral fluids. But major surgery, again, For the first 12 hours post-operatively, the chances of ADH secretion is maximum. So the post-operative fluid retention is really a problem. So you have to always keep that into mind and give isotonic fluids, measure the serum sodium levels every 6th hourly. Also, you can do is what? You give the maintenance fluid reduced by 50% for the first 12 hours. Actually, we are calculating the maintenance fluid still by holiday SIGA 4:1. So instead of that, you can go to 1.5. Also, the glucose, if a child is healthy, you need not to add that, and you can add it after the first 12 hours. Then give blood as indicated. Also, any abnormal losses, you can replace it ml for ml with 0.9% of saline and 10 ml KCl. And also you have to keep in mind that the potassium chloride should only be added if the urine output has resumed post-operatively. Generally, it does in the second post-operative day. So now we don't have this 1% and 2.5% readily available. So how do we prepare it? How do we do at our places? We take a 500 ml RL bottle, remove the 10 ml, add 50% of dextrose instead of that 10 ml, and you get 1%. So to make it 2.5%, again 25 ml you add, 5% 50 ml, and 10% 100 ml. Now colloids. Colloids in pediatrics, again a debatable topic, but it is indicated only when you have given 30 to 50 ml per kg of crystalloid solution. Still, you have not achieved normovolemia. Previously, it was thought it will alter renal parameters and it will further increase the need of transfusion. But recently, the meta-analysis has shown it doesn't do that. Also, albumin still remains the main colloid used in the neonatal period, and 5% is still preferred over the 20%. Now, blood transfusion. It's a huge topic, but I'll just tell the salient features in that. Blood transfusion, you have to always go for the transfusion trigger. In a healthy pediatric patient, it is 7 to 8 grams per deciliter, like that of an adult. Only if the child has a cardiac problem or any other malnourishment or something else, comorbid condition, then you have to take it as 10 to 12 grams per deciliter. Before giving blood transfusion, you always have to consider rally, circulatory overload, transfusion reaction. This blood transfusion, it always depends on the following factors: age, the quantity of blood loss intraoperatively, what was the baseline hemoglobin concentration when you took the child, also the blood physiology, that is hemoglobin F and hemoglobin A. So how you calculate maximum allowable blood loss? It is calculated as estimated blood volume into starting hematocrit minus the lowest acceptable hematocrit divided by starting hematocrit. And PRBC calculation, you do it body weight in kgs into desired hematocrit in hemoglobin in grams per deciliter multiplied by 5. So to conclude, any patient preoperatively, be it elective or an emergency procedure, please hydrate the child properly. The maintenance fluid, as per recent recommendation, is to give 10 to 20 ml of 20 ml per kg per hour of balanced salt solution with 1 to 2.5% of glucose. Isotonic or other balanced salt solution are the fluid of choice currently. Anytime needed, please measure sodium concentration and glucose levels and do the needful. If blood transfusion is needed to maintain normovolemia, when indicated, give blood transfusion. Permit oral fluids as early as possible as wanted by the child. So these are some of my references, and thank you all for your patient listening.
Good evening, everyone, and it's nice that you listened to two lectures very nicely by the postgraduate resident and then by the assistant professor, one on cuff tubes, especially micro cuff tubes in children, next perioperative fluid therapy, and the third, I think Dr. Maria Rose Jose from Associate Professor of Government Medical College Kannur is to talk on anesthetic management of tracheoesophageal fistula. Dr. Rose, you can share your screen.
Respected sir, I am Dr. Ashwati, senior resident from Government Medical College, Kannur. Today I am going to talk about tracheoesophageal fistula and its anesthetic consideration. Coming to introduction, tracheoesophageal fistula is a congenital defect that is thought to be as a result of a foregut malformation of uncertain etiology. It is usually occurs at the 4th to 5th week of gestational age. Its incidence is 1 in 2,500 to 3,000 live births. During the 4th week of embryonic life, trachea is differentiated from the esophagus. The region of the foregut, just caudal to the lung, develops into esophagus. Any error in forming the esophagotracheal septa or recanalization lead to tracheoesophageal fistula or esophageal atresia respectively. Endodermal lining is stratified columnar and proliferates such that the lumen is obliterated and patency of the lumen established by recanalization. Errors in this process leads to the esophageal stenosis. Coming to the classification, there are mainly two major classification systems. According to the Gross classification system, there are 6 anatomic variations of tracheoesophageal fistula with and without esophageal atresia. In this type C is the most common, which occurs in more than 90% of the cases. In here, a fistula exists between the trachea and the lower esophageal segment above the carina, while the upper esophageal pouch ends blindly in the mediastinum. This is the Wolf classification. Coming to the diagnosis, tracheoesophageal fistula is not easily diagnosed prenatally. The most common prenatal ultrasound finding associated with tracheoesophageal fistula or esophageal atresia is polyhydramnios, secondary to esophageal obstruction and the inability to swallowing amniotic fluid. Polyhydramnios is a non-specific sign and is caused by congenital anomalies less than 20% of the time. Another finding is the absent air bubble in the stomach in antenatal USG. The advantage of diagnosing antenatally is that it helps in preventing inadvertent feeding and pulmonary aspiration pneumonitis. In most cases, both low and high resource setting, tracheoesophageal fistula is diagnosed postnatally. You should suspect tracheoesophageal fistula in a newborn who is having difficulty in clearing saliva, repeated episodes of coughing and choking, transient cyanosis shortly after birth. Infants may present with a sudden onset of respiratory distress following attempts at feeding. To confirm the presence of esophageal atresia, a suction catheter is inserted orally or nasally into the neonate and is unable to be passed more than 10 centimeters into the esophagus. Diagnosis can be confirmed by a chest radiograph, which demonstrates that the catheter in the blind upper pouch on chest radiograph. In case of isolated esophageal atresia, we can see a gasless abdominal X-ray. In more than 50% of a newborn presenting with esophageal atresia or tracheoesophageal fistula, they have associated anomalies. Commonest being one or more associated with the Vactor group of anomalies. 29% of the newborns with tracheoesophageal fistula or esophageal atresia are associated with cardiac anomalies, and among them the common cardiac anomalies are VSD, PDA, TOP, ASD, and right aortic arch. Therefore, say ECG and an echo has to be done in order to evaluate for cardiac anomalies. Coming to the treatment, surgery is the definitive treatment of esophageal atresia and PEF. Generally, it should be performed in 24 to 72 hours after stabilizing the neonate. Delay in surgical correction increases the risk of aspiration pneumonia. So primary correction is either done by a right thoracotomy approach or a thoracoscopy. It involves isolation and ligation of the fistula, mobilization and anastomosis of the esophagus. And this is most commonly done in type C anomaly. The other methods are stage procedures or stage correction. Stage correction is done in esophageal atresia without fistula or in cases where mobilization of esophagus is not possible. Stage procedure involves primary esophagostomy and gastrostomy followed by correction of esophagus atresia, which is done 3 to 4 months later. Gastrostomy may allow egress of ventilator volume through the fistula and out of the gastrostomy. Therefore, nowadays it's rarely performed primarily. In case of a type E or type H, right cervical dissection and ligation of the fistula or a thoracoscopic ligation of fistula. In some cases, minimally invasive bronchoscopic application of tissue adhesive or fibrin glue is done. Thoracoscopic surgery is nowadays becoming popular. In thoracoscopic surgery, ports are inserted in the right hemithorax with insufflation of the carbon dioxide to a pressure of 6 mm mercury, which is usually accompanied by hypercarbia and desaturation. Therefore, the anesthesiologist has to adjust the ventilation accordingly. The tracheoesophageal fistula is then suture ligated and esophageal pouches are dissected, mobilized, and then anastomosed. Before surgery, there is need for preoperative risk stratification or prognostication is done. And there are mainly 3 classifications. And the oldest one is the Waterston classification. And in 1994, the SPITS has classified based on the birth weight. Here, 1.8 kg is taken as the safe body weight. And he also taken into consideration whether there is any cardiac anomalies present or not. If the birth weight is more than 1.5 gram without any cardiac anomaly, the survival rate is about 98.5%. And if the birth weight is less than 1.5 gram, and if there is a major cardiac anomaly, the survival rate is only 50%. And the latest one is the Okamoto classification. In this, they found that babies with a weight of more than 2 kgs without any anomalies have a better prognosis. Coming to the preoperative preparation, it consists of correction of dehydration, electrolyte imbalance, hypoglycemia, and hypothermia. Prophylactic antibiotics has to be given in order to reduce the respiratory complications. Surgery should be performed within the first 24 hours in otherwise healthy infants, and delay in surgical correction increases the risk of aspiration of saliva. Reflux of the gastric acid through the lower pouch and a tracheoesophageal fistula can cause pneumonitis. An echocardiographic examination should be obtained in order to demonstrate any cardiac or vascular abnormality. And confirmation of the reasonably normal hematological and biochemical profile should be sought, and blood should be sent for typing. Routine blood investigations like complete blood count, RBS, serum electrolyte, and coagulation profile has to be done, and X-ray chest should be taken. Coming to the anesthetic challenges, a neonate posted for tracheoesophageal fistula or esophageal atresia poses significant challenge to the anesthesiologist. The issues are ineffective ventilation due to the endotracheal tube being placed in the fistula, massive gastric dilatation, which itself can affect the ventilation further, severe pre-existing lung disease from previous aspiration of the gastric contents, then respiratory distress syndrome of prematurity, and associated anomalies, particularly cardiac anomalies. Anesthesia is usually induced in the operating room. Ensure the availability of all the necessary equipments. Forced air warmers to maintain the infant's core temperature. Oximeter probe in right upper limb. The upper esophageal pouch should be cleared by continuous suction applied to a Riplogy tube or repeated suctioning of the upper pouch and oropharynx. This is a Riplogy tube. Monitoring, standard ASA monitoring should be kept, and consider arterial line if unstable or blood gases are required, and temperature probe should not be kept in the esophagus. Different techniques have been done. Awake intubation without muscle relaxation and with or without inhalational anesthesia is a standard procedure. Another technique include induction of general anesthesia by inhalation with the patient in a semi-supine position. Once adequate depth of anesthesia is achieved, and with spontaneously breathing laryngoscopy should be done. An appropriate size endotracheal tube is then passed beyond the carina, aiming for endobronchial intubation. Then confirmed by auscultation, and the tube is withdrawn until ventilation is just heard on both sides. Ensure adequate air entry to the lungs after intubation, and always consider causes of inadequate ventilation, especially large tracheoesophageal fistula and fistula near carina. Larger fistulas of size more than 3 millimeters produce ventilating challenges. In some centers, bronchoscopic assessment is done, which helps in identification of the concomitant airway anomalies, including tracheobronchiomalacia, tracheal upper pouch, and tracheal stenosis. This will alter the decision to proceed with muscle relaxation. Bronchoscopy also will help to identify the correct site and size of the fistula. Many studies have shown that more than 67% of the tracheoesophageal fistula was 1 centimeter above the carina, so intubation is done distal to the fistula. Rotation of the tracheal tube such that the bevel faces away from the fistula, which allows ventilation of both lungs while offloading the fistula. When the tracheoesophageal fistula is at the carina or more distally, it is necessary to perform a bronchial intubation and one lung ventilation until the tracheoesophageal fistula is ligated. Some use of bronchial blockers or a Fogarty catheter to block the tracheoesophageal fistula has also been described. The endotracheal tube should be secured firmly in order to avoid displacement during the intraoperative periods. So airway pressures are kept to a minimum until after the fistula is divided, and the baby may be given a muscle relaxant and ventilated gently by hand. Excessive positive pressure ventilation is avoided till the ligation of the fistula in order to avoid inadvertent gastric distension. Maintenance position in thoracotomy, the baby will be positioned in left lateral position unless right aortic arch. You have to maintain the temperature, OT temperature. A soft rubber tube is passed through oral cavity into the upper blind pouch of the esophagus. This will help the surgeon to locate the blind pouch while performing anastomosis of the upper and lower esophageal pouches. Hand ventilation is often required, or as a spontaneous ventilation or a low volume positive pressure ventilation is done till fistula is ligated, and muscle relaxant may be given after the ligation. You can give analgesia with a local anesthetic infiltration around the wound, or you can go for intercostal blocks. And you have to be very close attention. We should be kept in blood loss and fluid management. Intraoperative considerations, desaturation and hypotension during the retraction of right lung may occur and should be carefully watched. Surgeon may be asked to relax the retraction intermittently. Desaturation also can be there due to kinking, displacement of the endotracheal tube, or blocking of the endotracheal tube. So the endotracheal tube should be suctioned intermittently. The integrity of the repaired fistula is tested by instilling saline in the thoracic cavity and applying positive pressure ventilation. A nasogastric tube is inserted by the anesthetist and placed by the surgeon into the stomach before completing the esophageal anastomosis. Patient should be monitored, post-operative consideration. The patient should be monitored in the pediatric intensive care unit. IV fluids and broad spectrum antibiotics has to be continued. Analgesia and sedation, you can give morphine 10 to 20 microgram per kilogram per hour infusions. If the anastomotic repair appears satisfactory and there is no other indication for any artificial ventilation, the trachea should be extubated as soon as possible. In patients with major cardiac anomalies, in severe pneumonitis, in premature sick babies, and in tracheobronchomalacia, you have to ventilate the patient post-operatively. The re-intubation is detrimental to the anastomosis. And be careful, avoid hypothermia, avoid undue extension of the neck to avoid damage to the anastomosis. You can consider giving an H2 antagonist to reduce the effects of gastroesophageal reflux, or care of the nasogastric tube should be done. Accidental dislodging of the tube is to be avoided. The nasogastric tube should be secured properly during the post-operative period. Transanastomotic tube feeding is usually started by 48 hours after surgery. Complications. The early complications includes anastomotic leak, which is seen in 11 to 21% of the patients, and it is manifested by pneumothorax and salivary drainage through drain. And another early complication is gastroesophageal reflux as a result of a reduced neuronal tissue in opaque plexus, or it can be from intrinsic esophageal dysfunction. Here, the management is conservative. In about 6 to 45% of population, fundoplication is done. The trachea retains a wide membranous section compared with a normal C shape. This abnormality can lead to a tracheomalacia of varying severity. The late complications include recurrent pneumonia, aspiration, esophageal stricture, dysphagia, and these patients have chronic bronchial hyperactivity, recurrent bronchitis, and wheeze. Prognosis. Generally, the mortality rate of esophageal atresia or tracheoesophageal fistula remains on the decline and is currently less than 1.5% for patients without major cardiac anomalies and with a birth weight of more than 1.5 grams. Summary. Proper preoperative assessment and preparation has to be done. Careful assessment of the prognostic factors like weight, severity of pneumonitis, prematurity should be done. and evaluation for congenital and chromosomal anomalies has to be done. And the major consideration for both anesthetist and the surgical management of the neonate is ventilation of the lungs without ventilation of the fistula. Both in case of open and thoracoscopy technique, the anesthetist must be vigilant to changes in airway pressures, tidal volume, and tidal carbon dioxide that may occur as a result of surgical compression or kinking of trachea or bronchi in order to improve the surgical access. And postoperative care is also very essential. Pain management, parenteral nutrition, avoidance of hypothermia, etc. Thank you.
Minakshadram, can I start or?
Yes, sir. Yes, sir.
Okay.
You can.
Yeah. Thank you. I think you can stop sharing, and I think three people, Dr. Gina, Dr. Sajina. I met it at Mary Jo's. I think that was the initial communication. I think, sorry, it was Dr. Aswati who was done a tracheovisual fistula. I think three of them have done really very well. They have done a lot of work, homework, and did the work. It looks like a really postgraduate teaching where it's every small points are very clearly written, and so it has been done some work, and it's any postgraduate will be any theory question of fluids or cuff tubes or with this one, they can really write very clearly with all the things. What there are some questions, what we can do is there are some questions which has been there. I'll post to the persons who are presented the paper, because not that to just to, because let me see that whatever they can answer, and we give anything we can always add on to that. There's no problem with that. I think they are okay. So I will start with probably with the cuff tubes, which has been there are cuff tubes which has been done by Dr. Gina. I think she can just video, and your mic can be really unmuted. And there is a question in, will the fresh gas flow can be lower if you are using a Jackson-Rees circuit? See, if you told that fresh gas flow we can be less comparatively low fresh gas flow. In case if you are using a Jackson-Rees, can we in spontaneously breathing, can the Jackson-Rees your flow can be reduced using a cuff tube? Just attempt your answer. This is the question. Doesn't matter. Everybody has done mistakes, and nobody become an expert just like that. So you can attempt your question, whatever it is, what you think. Most of the questions you want to read, you just need little bit of a common sense into that, and just you can answer. Yeah, this is a posture question. Whatever you feel, you can tell. You're unmute. You are not able to listen.
Minimum flow should be kept.
Sir, I think Dr. Dinan's voice is not at all heard. So I think
Dinan, yeah. You are muted.
Am I audible?
Yeah.
I think a minimum flow should be kept.
No, not audible.
No, she says minimum flow can be kept. But what is that minimum flow?
4 to 6 liters, sir.
Pardon?
4 to 6 liters.
For all age? The question is actually, this is a question that's okay, but what is you told fresh gas flow can be minimized by using a cuff tube, okay, because if putting a cuff tube there is no leak around the tube, so you are giving a low fresh gas flow, like a low flow anesthesia. But can the same can be given if you are going to give in Jackson-Rees? Actually Jackson-Rees, what is the flow normally you give?
1.5 times.
Just already told, it's actually 2.5 times, whatever, 2 or 3 times the minute volume. So if you're doing a Jackson-Rees and you put in a cuff tube, can we reduce that flow to 1 times the minute volume or 1.5 times? That is the question he has asked.
Rebreathing will take place.
No, see, because see in a whatever answer you are telling is quite low flow can be given if you put a cuff tube in a closed circuit, because you are going to have a rebreathing in that, and that you can reduce the flow to 0.5 ml or 1 ml if you have cuff tube. That's understandable. But if you are on spontaneous, whatever you are going to give, you can't reduce the volume unless you want to give the same tidal volume of about 2.5 times a minute volume. Spontaneously putting a cuff tube, you will not be able to reduce your flow. That's the main answer. It's the same flow you have to give it, because there is no rebreathing, and if you are giving a low flow, there will be rebreathing, then it will be a problem. So it is not really right. So whenever you use a Jackson-Rich circuit, you think of three things. One is the weight, second is the dead space, third is the rebreathing. So all these things cannot be stopped using cuff tube, because again it will be open by Jackson-Rich will not, you cannot reduce your flow. Any comments by anybody? Dr. Nagasamy was the one who I asked, but I am not sure whether he can, he's not there, but I think I just want to, anybody can answer. I think this is my opinion about that.
Well, true, sir, because whether there is a leak or not, you cannot change the spontaneous flow in the Jackson-Rich circuit. But again, regarding this flow, Dr. Zenon's speech was having low volume. That is the problem. That low volume is a problem.
That's okay. I think it's
that is right. That is
okay.
right. It cannot be decreased.
Okay. Okay. The second question is probably Dr. Muthukumar. Post extubation strider, does it because it will be more common with the microcuff tube or uncuffed tubes? Post extubation strider, will it be common in the microcuff tubes or uncuffed tubes?
With the cuff
I
tube.
think this you can answer.
No, I just wanted to answer, that just to see if you can see.
Sir, because this expertise is anyway, she's a postgraduate.
Yeah, doesn't matter.
You can answer this.
No, just okay. See, this is my opinion. I am sure people can verify. See, I think the strider, post extubation strider, is really nothing to do with the cuff tubes or with the help of uncuffed tubes. It is if using a larger uncuffed tubes or a cuff tubes is not a proper size, not properly inflate. I think that both people have had the same with the microcuff or the uncuffed tubes. If you have not used a proper size endotracheal tube or inflated more with the tubes, I think the post extubation strider and laryngospasm is the same whether it is a cuff tube or uncuffed tube. There is no going to be a change in as far as it is the technique and your depth of the anesthesia which is going to matter at the particular time, how you are going to use it. There is no difference. Any comments by anyone?
100% we agree with the chairperson.
Muthukumar, you are okay? The other question is,
yes, they will be listening, sir.
No problem. I'm just microcuff tube. What is the incidence of microcuff tube causing mucosal ischemic damage? Any idea? No. Okay. See, the microcuff tube, I'll come back to your presentation, three things which I just want to correct. I just want to see you are correct in that. See, the microcuff tube, Dr. Sangeeta, can you mute your mic? Dr. Sangeeta, okay. See, the microcuff tube, okay, the microcuff tube, that's why it doesn't mean that microcuff tube is 100% safe, because if you are overinflate that and if the cuff is overinflated and if it's come in the vocal cords, there will be definitely mucosal damage. That has been very clearly you must be very, very careful when you are inflating the microcuff tube. It can happen. But one first slide you put, it's a high volume, low pressure cuff. Do you agree with that? How much volume you put? I'm not, this is just a practical. In a micro cuff tube, you put only 0.5 ml or 1 ml maximum. So this is not high volume, low pressure cuff. So this is actually, this is a micro cuff tube which is a low volume and it's a low pressure cuff. So it is not high volume. High volume cuff is quite long, and so it is not used very high volume. So micro cuff tubes are not high volume cuffs. You need only 0.5 ml or 1 ml. I think the high volume low pressure cuff is not a correct terminology as far as micro cuff tube is concerned. The second, the depth mark. You are talking about, see, all the endotracheal tubes will have only one depth mark, okay, that's a black. So you keep the black and the cord level, that's what acceptable. Here it's a depth mark which is black, which is thick. After that there are 4 marks which is distally, and that 4 marks in the microcuff tubes is called as a alert bars. Okay, please remember, this is not the depth marker. The depth marker is that one which is thick. The remaining is called as the alert bars. Okay, this is alert bars. You told me you keep the depth mark at the cord. This is not exactly true. You can push, if you have other tubes with a depth marker, if you push beyond the vocal cords, we don't know how much has it gone inside. That's why the 4 alert bars tells you. If you see 2 alert bars is okay. You don't need to see all the 4 alert bars above the vocal cords. If you do like that, then what will happen is it will have the cuff might come near the vocal cord. So it's better 2 of the alert bars goes inside and 2 are seen. I think that alerts you, because that's why it is called as the alert bars. So it is not the depth marker, only one depth marker and 4 alert bars. So this is a very nice. If you have a, probably if you put the tube, 1 or 2 goes inside, the remaining 2 see it's okay. All the 4 should not go inside, because that will become endobronchial intubations. So at least 2 markers should be seen, that is called the alert bars. Okay, this is how the microcuff tube is okay. Third, you told at the conclusion there's a disadvantage is Murphy's eye. Is it a disadvantage or an advantage?
Advantage. It's advantage.
See, there was a Murphy's eye in all the endotracheal tubes. In the microcuff, they removed the Murphy's eye. So is it, you told at the end there's a disadvantage. I just want to ask you, what is the advantage of Murphy's eye and why there is a disadvantage of Murphy's eye? Why there was Murphy's eye was there before?
The endotracheal tube gets blocked. There is an alternate way of ventilation using Murphy's eye. Since in microcuff tubes the cuff is distally placed, the Murphy's eye is absent.
Want to hear?
No, that's quite okay. I'll just have to Meenakshi, can I explain? Is it okay?
Yes. Sir, you are totally, people are waiting for your.
No, I just couple of points. I just give a lecture like that, but just whatever
sir, you have to, because many people are listening, and see, we cannot expect the postgraduate to answer the tricky questions.
No, I'm not asking. It's not a viva to you, Jinan. I just want to know how much you are understanding. That's all. It's nothing that it's okay.
You have to explain.
Yeah. See, this is actually when your Murphy's eye, the Murphy's eye was below the vocal cords. So when it is below the cuff, usual cuff tubes. So when the Murphy's eye and go there, it's a large one. The cuff will be very distally. So there will be lot of length. The cuff will be there, and if you inflate, it is near the vocal cords. There will be vocal cord damage. That's why the Murphy's eye is removed in the microcuff tubes. Okay. So you correctly told that when Murphy's eye, if there is a small block in the endotracheal tube, there will be Murphy's eye, it will be ventilate. It is not at all practical, it is only theoretical. If the Murphy's eye is there, doesn't mean it will ventilate. The block will be there in the whole endotracheal tube very clearly. So I think the Murphy's eye, it is not really very useful what it was taught. Instead of this, Murphy's eye is a disadvantage in children. I am not about that because it will increase the length between the cuff and the tip of the endotracheal tube. So the microcuff is tube, you don't have a Murphy's eye. It is an advantage because the cuff is very close to the tip. So when you below the vocal cord you put it, there is no endobronchial intubations. I think Murphy's eye is, though it was introduced with a good sense, but it is not practically, I think, very useful. That it is blocked means it will blocked. Murphy's eye, it is not really very people said if you put in the left side endotracheal tube, the right Murphy's eye ventilate the right bronchus. It is not very practical. So I don't know what is Meenakshi's opinion about this.
That's true, sir. It is
No.
true only because that flow itself, it will not be a laminar flow. Even if it moves like that, in positive pressure ventilation, when the gas escapes through the side hole, it cannot enter the trachea exactly like a tracheal lumen. It will not follow the laminar flow pattern. It will be a problem only. Previously, now, sir, even if that tip is blocked, we know there are so many gadgets, the bag will be tight, the airway pressure will be more, because now we have electronic gadgets also. So now it is obsolete, that Murphy's eye, even in adult, adult.
Yeah, I think though, so that's why even Murphy's eye is removed, and this is not really, I am not actually a company owner of Murphy's eye, but I am just of a microcuff tube, but I am a very proponent of microcuff tubes. There are definitely, it's a lot of uses in that particular uses. The fourth important thing, you told the cost, okay, the price. I can, all the people, I just want to tell you, the cuff tubes is now, it was very high those days, now it has come to probably the MRP is 1200 to 1300, whereas if you buy from where the cost price, you can between 650 to 700, you can buy the cost price. Okay, see what's happening now, I just want to tell for other people, is in a child, I don't know about the private hospital like this, in a small child coming for major surgery, it will come to about 1.5 to 2 lakhs or 1 to 1.5 to 2 lakhs. Okay, they do laparoscopy, they do robotic, they do everything. Why should we save about 300 to 400 rupees in the endotracheal tube? See, this is my way of thinking of the people, but it may not be available in a government hospital. That's a different story, but it's very expensive and all. This is not generally. I feel that if you put an endotracheal tube which is leaking, low tidal volume, you keep changing the endotracheal tube, you will have a trauma, then you will put a bigger tube, then bigger tube will cause edema, and because microcuff tube is expensive, you will use what is called either a Portex tube or a Teleflex tube, where the cuff is very large, it will cause vocal damage. So I think when you considering all, changing in the tubes and your low flow, control ventilation, and the material is very good, I think we can worth. I was also thinking those days, about 10 years ago, it's very expensive, but after using all, I believe that don't hesitate in case they can afford. I think better use a micro cuff tubes. I think that's don't use any other cuff tubes. I think that will cause more damage, and even if you see any other tubes, the cost price will be about 200, 300, MRP will be 900. So what is happening is the difference, only the hospital is gaining, but the patient is not gaining. So my suggestion is, in case you are affordable, please do not hesitate, use a microcuff tubes. That will solve all your problems, which has been very clearly, it has been told. Is there any argument against this? Anybody doing pediatric anesthesia can I think this is what it is. Because somebody told cuff tubes, do not use any other cuff tubes. If you want to use microcuff tube, but all sizes may not be available in every place, but one tube which is very close, little more close, what is not see, the Teleflex Rush tube is the worst. I hope Rush people are not hearing. The Rush tube is a very short. When you introduce a lot of cuff is length is too much, there will be injury. But if you want to use it, Mellingrat is a little bit better tube than the Rush tube. If you want the alternative to a micro cuff tube, it's not. But if at all you have to use Mellingrat, which is little more better. Not Portex cuff, not Rush. Mellingrat is slightly better tube than the other cuff tubes. This is the preferable, and this is what the cuff tube is. Okay. Any question there? Can we reuse micro cuff tubes? I think definitely, because if you have, this is very common, because we are using, what you do is, if possible, for about 1 hour hernia or 1 hour laparoscopic appendicectomy, you use something like micro cuff tubes, very good lung. If you are deceased lung, deceased patient, do an ARDS, infected, please throw. Yeah, otherwise you can use a micro cuff tube and then you can wash it, and if possible, I always do with the ETO. You all collect it and put in it, it's the ETO sterilized, and you can use reuse a micro cuff. According to a single use, but you can wash it and you can put it in a ETO, collect it all. There are ETO machines these days are available in one of the nursing homes. You can pack it and send them, and then you can use it. What I do is, in a small surgery, I will keep the cover of the endotracheal tube. I keep it. Once you use it, I extubate nicely and then wash it, put it in the same cover, and then put in a ETO sterilization. So I think it is better than using an other tubes than the micro cuff tubes. It's a little expensive but difficult to get many times, and because of the Ukraine war and Chinese imported things like that, sometimes you may not be able to get it, but I am sure the patency of that is lost. I am sure someone will come with the micro cuff tube than the Kimberly-Clark or Avanos. What about Portex tube? I think Portex tube, cuff tube is also not very good in children, because there's a Murphy's eye and the cuff is quite large. It's a large volume, low pressure cuff, but you will get larger volume, and that is not really very useful. If you want to use it, I have tried all, and now I cannot show the pictures, but I compared all the cuffs together, and the same size of micro cuff tube is 3.5, is in a Roche is only 2.5 cuff tube. So it's the inner diameter becomes very small when the cuff is larger. So you are compromising on the inner lumen but using the other cuff tubes. I think that's not very good. And alert bars is okay. And the fourth about the pressure, actually the pressure monitor, see, for example, people have what the advantage is that if you people those days, I am sure other senior people, I don't see them all, but Meenakshi will remember those days. If you put uncuffed tubes, you just put 25 centimeter of water. That particular time you must have a leak at that particular time, otherwise you change it a smaller IR. So number of tubes you change will be 3 tubes, and 3 tubes cost is the same as a single micro cuff tube. So instead of changing the tubes, trauma, and I think it is okay. I think that will be quite advantage use a micro cuff tube. I think let us stop with the micro. Any question of the micro cuff? I'll stop. I'll go to the fluids. Okay. Second is the fluids. See, I think that that's written. The question asked is that the anesthesia fluids by actually Dr. Nagaswami's comment is IU fluid, perioperative fluid should be classified into neonate, infants and older child. I think it's a very difficult exactly tell in a part about 30 minutes of time to divide. I think I think there is a difference between neonate and infant and older child. I think this is a broad topic, and it is you can choose whatever the right. I think that's okay, and all the basic physiology is very well covered. It is not actually practitioners forum, it is for the postgraduates. I think they're okay about your composition and tonicity and everything is okay. The question he asked is how many kids take, I think he wrote clear tea, but we don't buy a clear tea. So how many kids in India? I think when you are probably what is again is that there will be something what is written in the books and the guidelines. It may not hold good in an Indian condition. So you must change it, because don't use the same clear tea. So the question he himself asked, how many kids take clear tea? So I think that's it's okay, but you can change it. You don't have to, when you are doing it, prepare it for the Indian conditions. Don't have to you read a lot of books and make it for your convenience, for your situation. I think that's the more important. That's okay. And what is the dose of clear fluids? You written there, they think.
Actually, sir, it's
3 ml per
not clear
kg.
fluids. It's if water. They're telling it's less than 3 ml per kg. You can give until 1 hour.
3 kg.
And there was a study in which they said if you are giving clear fluids, you can give up to 10 ml to 15. But only I saw one study saying that 10 to 15 ml per kg clear fluids up to 2 hours, and water less than 3 ml per kg. Yeah.
3 ml per hour.
3 ml to 10 ml per kg, just a clear fluids. So this is one thing is about this. I think these are all guidelines. Guidelines doesn't mean that you have to follow all the guidelines. It's just a guideline. So you see, European guideline, German guideline, Indian, all guidelines are there. But if you go into it and people are doing only pediatric anesthesia, I think they can follow these guidelines, because it all depends upon your experience. See, you tell me that 1 hour before you can give clear fluids. We don't know India, they don't know, they think milk is also clear fluid, so 1 hour before they will clear fluid. If he is an experienced pediatric anesthesiologist and they know how to ventilate the mask, during the ventilation you can find out the child is trying to vomit, immediately you will do suctioning and all these things. I think all these guidelines depends upon the experience. None of the guidelines get into the factor of the experience of the anesthesiologist at the particular time, because somebody says you can give up to 1 hour, adult anesthesiologist who cannot really hold the mask properly at that particular time, I think they will just ventilating too much and the stomach will be distended, vomiting. I think guidelines, it is good, because all German guidelines, Swiss guidelines, British guidelines are done in a children's hospital, were not by a pediatric anesthesiologist, and it is for the pediatric anesthetist. So how many in India we are practicing? I think it's very rare. Maybe about only 5% will be practicing, not 5, even less than that, practicing exclusive pediatric anesthesia. Less than 5%, I can tell, in the whole country. So I think you must take with a pinch of salt about all these guidelines. This is okay for exams, but if you want to practically, please still follow only 8, 6 and 2. I think that is the better way and safer if you are not really a pediatric anesthesiologist, but it is good to know what's all happening. Is that okay? Okay. About the, I just want to Sajina, what is the another one, 15 minutes, only 2 more questions is okay. The risk of hypoglycemia, is it the risk of hypoglycemia? See, what is the change happened in the fluid therapy? Why dextrose was introduced, and what is the present situation? Just 2-3 sentences you can tell. You told everything, but just summarize for the people.
So before dextrose was added in the holiday cigar thing, and it further made it hypotonic solution, because the dextrose suddenly dissolves and it gives calories, and then it's only water. So now what is they saying that hypoglycemia, if a healthy child, it's not of much concern, and if you want to keep a normoglycemic state, you can add 1% to 2.5% of glucose in an isotonic solution, and give that child to continue with the normoglycemic state. But in some other children, if like preterms or neonates and some other comorbid conditions, according to their need, you can increase the glucose concentration.
Yeah, that's very clear. One. The second is that when we were being taught 40 years ago, any children, we must start with 10% dextrose. That was our teaching old. I'm talking about 40 years ago. Then they made 5% dextrose. Recently it said no need of dextrose solutions. Now recently they've added no dextrose, but it is 1 to 2%. Okay, there is some history in that, because if the child gets an arrest intraoperatively, what happens is, if there is hyperglycemia, it causes cerebral edema and hyponatremia, dilutional hyponatremia, and the prognosis becomes bad. That's why the dextrose was taken off. But what happened now, most of the, when you give, you are talking about when you give already anesthesia with a stress, you are increasing blood sugar. But what happens in children, 80 to 90% we give regional block, where caudal block or epidural or local TAP block. That means when you give a regional block, the stress response is already blunted. So there is no question of hyperglycemia, they will go for hypoglycemia. That's why those are the children you add at least 2% of dextrose. That's why initially there is dextrose, then no dextrose. Now they found hypoglycemia when they were regional blocks, because that's why you had 1 or 2% dextrose. And all the other patients, more dextrose is indicated in last conclusion slide you are given, when there is a diabetic child or in child with when you give a regional blocks, all these things, you in a cardiac cases, all these things you must give a dextrose. But in case you were giving a dextrose more than 2 hours, please do blood sugar level. I think that will give you an idea, because these days you have got a glucometer, just check the sugar if it is more or less. That will reduce a little bit of your problems because of this. So when you want to give fluids fast, give non-dextrose solutions. If you want to give it slow for maintenance, give little 1 to 2% dextrose solutions. I am not talking about a post-op solutions, all these things. I think this is what it is. It's maintain this, and this is the change in the why this has happened. Any question in that? We are just going to the last one to TF. Another 10 more minutes, so I'll just go into TF. I think that's okay. Any question in the fluids? Other thing I just want to finally I just want to tell you that there's IV fluids of choice in less than 40 in TF, and can we give ringer lactate in a newborn baby? Okay, 2 questions I think this it is asked. You want to answer, Sajina?
So for the newborn baby, I will say less than for 24 hours, there's something called the postnatal diuresis, which generally happens after, by 3rd day. So giving a sodium normal saline which has so much high amount of sodium won't be right, because they are already loaded with the sodium thing. So I think better to go with fluids which has a isotonic range of sodium, like 130, or like our plasmolite will be better in that conditions for less than 24 hours, I think so.
No, that's okay. So coming to the final, I'll just conclude this. I'll come back to TF. The situation is, there's a difference. People think that plasmolite is a better than ringer lactate. It is not same. It is not true, because ringer lactate causes lactic acidosis. You yourself in the slide you put lactase is converted only bicarbonate. So there is no lactic acidosis with ringer lactate, and so they say the ringer lactate, the plasma is better. And plasmolite, whatever the gluconate, they think they have acetate, because it's acetate there is no lactic acid, so this is a better. The second, because of this gluconate are not metabolized, so there is a lot of alkalosis than acidosis. It doesn't happen because gluconate is not metabolized. Gluconate in the plasmolite is excreted as such into the kidney, so it has no value. I think except in liver transplants, plasmolite is not better than ringer lactate. I think that's very clear. As a practically, they are just marketing as a plasmolite is better, but plasmolite for normal patients and usual patients, it is not better, because the liver, the plasmolite, it is not degraded by the liver, and that's very metabolically it's very safe. So in case of liver transplants and major surgery or resections, that way plasmolite is better. 95% ringer lactate and plasmolite are the same. There's a lot of myth that plasmolite is better than ringer lactate. It doesn't all good. Ringer lactate and normal saline, because normal saline will causes more of because of the chloride, it is hyperchloremic acidosis. So you always normal saline, you know, it is not always normal, so it's better you give a ringer lactate. I think ringer lactate is given. People say the ringer lactate causes a little potassium. Potassium is only for about 4 milliequivalents per liter. So in 500 ml only 2 milliequivalents. Of that only point, if you give 100 ml, it will only 0.25 of potassium. So it doesn't make any sense. So don't have to bother about giving a ringer lactate. So still ringer lactate is a better, even in whatever this one.
Yes.
Okay. Coming to the TF.
Sir, 1 minute, Chairperson, sir.
Yeah.
One question is asked whether trolley is common in newborns. pediatric age group.
Oh,
Trolley, because
trolley.
they are talking about blood instead of fluid. They have asked when the blood is transfused.
No, no. Yeah, that's, I didn't see the question, I think. Sajina, you want to answer?
Sir, actually, trial is not as common as in adult in pediatrics because it is a clinical diagnosis. It's not something we measure and all, but it's still common in pediatric population, especially the kids with cancer and they are undergoing a surgery. Hematological malignancy. In that condition, the blood transfusion reaction trial are more common, but it's not as common as in adult.
And to be frank, I have not seen a trolley in neonate because it can be trolley in whatever you call transient reaction, but before the trolley, the child will have pulmonary edema. So it doesn't have, because if you give more blood, what will happen is more of pulse and it's a more fluid in a neonate. It's older children. I've been in scoliosis about maybe 12 years, 14 years, massive transfusion. I got 2 or 3 cases of trolley, but not exactly in a neonate. I don't think I've seen a report of a trial, the specific terminology of trolley in neonates. I think that is not there.
Same way, sir. Another question is there. What is the difference between osmolarity and tonicity?
Yeah, Sajina will answer. Yeah.
Sir, actually, this osmolarity is number of solutes in a solution, but tonicity, it doesn't has a unit. It is like what a solution does to a cell. So it depends.
Fantastic.
Like I have shown in the diagram, that is intra cell swelling, shrinking, normal thing. So it also depends on the solution as well as the cell membrane. That is the tonicity. It is just doesn't have a
Excellent.
unit. It's term actually.
Yeah. Meenakshindram, I didn't know the answer, so I transferred it to Sajina, because I didn't know what is tonicity osmolarity. See, that's good to be an examiner like this, so it transferred to students. What do you say? Then I will see, now I can get the answer from them, So
Her definition is good, sir. Her definition is good. I want to add another question people will ask. What is the difference between osmolarity and osmolality? L and R. Again, the difference is, now I will tell the answer. The difference is osmolarity is per kg of solution. Osmolarity is per liter of solution. These are all, just as an examiner, they want to ask the people who are answering very nicely, but it will not carry any, they will not decide pass or fail. It will carry some extra marks.
Yeah, very nice. This is a common question. This is a common question everybody will ask, especially any fluid. They'll ask osmolarity and tonicity and what is isotonic. It's a very common question with in every exam, basics one, which is okay. Okay, again I just want. I think this Aswati is around. Aswati, okay. So you actually during the induction, Aswati. During the induction, another about maybe 7 minutes, I'll finish. During the induction, I think the statement is that awake intubation with or without muscle action, spontaneous, deep. In the same situation, you put all the marks in that. I don't know whether you are going to give awake or you are giving a muscle accents or you are going to do. So I think even in that first sentence, that intubation can be awake with or without muscle action, with inhalational, without inhalational agent, with deep or you can. So all the 4 were there in the first sentence. So what is your way of intubating the child? Aswati.
Is there or not?
Yeah, she's there. Yeah.
It's audible. She has to unmute.
No, I just want another maybe 6 minutes. I'll finish. Is okay.
Sir, actually, I have not given a case of TEF before, and from the study materials I've gone, it is said that traditionally they used to go for an awake intubation without any muscle relaxants, but in neonates there was an increased risk for interventricular hemorrhage and all. So nowadays, they are also giving muscle relaxant can also be given and intubation can be done, and the success rate is high only.
What is your concern at that particular time? What is your concern? I know you're not done. I'm just wanted to, so that, see, if I keep on giving, the people may not understand, so that I want to ask questions. What is your opinion? What is your concern at that particular time?
I mean, the main concern
Regurgitation.
in tracheoesophageal fistula is whether aspiration can occur, ventilation will be difficult because gastric insufflation can occur, and that itself can lead to a gastric rupture, and again ventilation will be affected further.
very she understood very clearly, everything has been told. See, if you, there are two ways. There is no question of awake intubation, very clear, that's gone. Okay, there is no one, please understand, there is no question of awake intubation at all. Okay, the question now is, will you give deep with spontaneously will you intubate, or you give a muscle relaxants and intubate. See, the for example here, every book or every practical thing, you keep spontaneously, put the tube. Once the ligation has been done, then you can give a muscle relaxants. I think that's being done even in advanced center and all these things. The people who are little more overconfident, they will say, okay, the surgeon is very good, he has scrubbed already. In an expert situations, we can always put a muscle relaxants, then put an intubate, go quickly and ligate the muscle, but you should be an expertise. The advantage of giving a muscle relaxants will be less trauma. You can give a bigger tube, because you put a bigger tube, that's why you are suctioning, because during the tracheostomy fistula a lot of blood will come inside and then it will block. So if you have a bigger tube, easy to suck it. So the ideal and book teaching is, give a inhalation agent, keep it deep, spontaneous, then spray the cards, put the tube, and once you put the thoracotomy, ligate the fistula, then you can give a muscle relaxant. That is very, very ideal, because if the fistula is very large, then you give a muscle relaxants, like what Ashwati is telling, if you ventilate, it will leak into the fistula and you may not be able to ventilate the lung, it will go into the stomach, big distension, there will be a problem. So if you are an expert, good pediatric surgeon, a good institution, you give a muscle relaxants. Otherwise, safe is spontaneous till ligation of the fistula, then you can give a muscle relaxants. Is that okay? What is what happened? The main problem during this is that during a tracheostomy fistula is desaturation will happen. It was about 94, suddenly it will become 60. Okay, what do you think at that time happened? She is not done it, so I don't want to create problem with her. But when there is a saturation is low,
Secretion.
one is secretions tube might got, or blood can be blocked. But when they are retracting the lung, many of the residents will retract the trachea and bronchus also along with the lung, you may not be able to ventilate. So this is an important lung, if you retract for long, it is not good. So that lung is also diseased, you lung, and they will compress the normal lung on the left side. So you must allow the person to retract it to be taken off, ventilate again and ask them to go back. I think that's how you, because you will desaturation will be very fast. Third reason is, when they are putting the tube and they are already retracting, what the normal tube just above the carina might go into the right side, already right line they are all retracting and become endobronchial intubation, there will be desaturation. This is very clear. Third, very important, usually we use precordial stethoscope, but these days we don't, many of them don't know precordial stethoscope. But this tracheostomy fistula, please put a precordial stethoscope on the left side. Please put a precordial left side, because when they are doing a fistula and there is a fistula is being ligated, they put a bulldog clamp. They put a bulldog clamp and see whether left lung is ventilated or not. If the left lung is not ventilated with the precordial stethoscope, the bulldog tag is in the trachea. People have ligated the trachea during intratracheal fistula. So this is not very uncommon. So in case of tracheal fistula, however monitor is available, please put a precordial stethoscope on the left side. If there is a they put the bulldog and there is no change in the left lung, then they can ligate that fistula. I think this is a very, very common and it can happen like that. I think you must be very practical in that. Finally, I just wanted to answer one solely that what is the fluid of choice in tracheovascular fistula. I think this is a very, very important. This is, you always do an echocardiogram. One is to know associated anomaly. If it's a right arch, because if it is a right sided arch, if you do a right thoracotomy, then people have to close, then go to the left thoracotomy. If right is arch echo, then you do a left sided thoracotomy. I think that's a very important one. And then if there's a PDA is there, you always reduce the fluid in that. So if you want to reduce the fluid, any thoracotomy in a newborn, don't keep on giving crystalloids. You change over to colloid after 10 ml. Probably if you want to use it, the best probably the albumin, but the albumin is very expensive, you may not get every place. You can use fresh frozen plasma. So FFP is a good colloid if you want to use it. Post operatively, any discharge in the lung one side, whatever the fluid in the bag, is to be replaced by the colloids. I think that's the main reason, the blood loss to be replaced by the blood. Usually TF, there is not much of blood loss, but there is lot of colloid loss, because thoracotomy will lose lot of proteins. That's why you use albumin or fresh frozen plasma, which is easily available in many of the FFPs are usable to 10 to 20 ml per kg. Instead of give more fluids, whatever the PDA physiologically closed will open up. Then we have to do a PDA ligation, then only you can take off the ventilator. I think that's a very important thing. I think to summarize, I must tell you, you have given a lot of opportunity to explain each and every point. I must thank the Pudukkottai Budan to give me an opportunity and teaching the postgraduates and my colleagues and my friends who are all there. And whatever the small, all the three people did extremely very well, especially like a postgraduate teaching. But I did little for my experience. I've joined the points. Not I'm just correcting them. I'm just whatever that experience is different what you read in the books. So I think that's how we have added, and we call it, this is like what he says, a geriatric and pediatrics. I'm a geriatric and 35 years, and that is the wisdom. So I think that is not the knowledge, but this is the wisdom which has gone to it. I'm trying to easy to transfer the knowledge, but easy difficult to transfer the wisdom. I think that's important thing. Not that I'm correcting all the three speakers, I'm just adding on to the points so that they can remember. I think they start exactly at 6. It is 8:02. Dr. Meenakshi, thank you so much.
Thank you, sir. Thank you. See, at last we have seen a message from Dr. Varsha Vora. She has mentioned very good webinar, practical tips from Dr. S. Ramesh. See, that's what Pudukkottai Budan like to have, and we encourage new speakers, interested speakers. It should be covered by expertise. It's the exact blend between the beginning teachers who are beginning their career and the expertise from the highly experienced person. Now, I like to take a photograph with Dr. Ramesh, just like Dr. Ramesh is with Frederick Berry. I will be taking a photograph. I have taken a screenshot actually, because just like you are with Frederick Berry, we will be with Dr. Ramesh. Now, I hand over the session to our President, Dr. Suresh Kumar, sir.
I think just to conclude, I think Meenakshi, I see all your webinars, all your thing. It's a really very nice. It is something like a IPL, because unless you pay in IPL, they can't select for the country. So you are given all young people to talk. Otherwise, only Ramesh will be talking, and people may not like it. Now, Sajina, Ashwati, or even Gina can come to the talk. I think that's a give experience. You make like IPL, they're selecting for the country. I'm sure this Pudukkottai people, you are encouraging all young people who their names I have not even heard about them. I think it's a great privilege they are given to young people. And thank you, sir.
That is the reason why we are not requesting you to deliver the talk, sir.
Enough, sir.
You can cover the whole subject.
Yeah.
No, as a chairperson, you can cover the whole subject. If I give you fluid balance, we will be. That is the reason why we invite, and we are happy. All senior people are obliging us. That is the point.
Good,
sir.
Sir,
Over to President Dr. Suresh Kumar, sir.
Thank you, sir. Thank you, ALM, sir. Thank you, Ramesh, sir, for your excellent practical eye opener on the endotracheal tubes, IV fluids, and a part of tracheoesophageal fistula management. I thank all the three speakers who have excellent presentation. Now our treasurer, Dr. David, is waiting for vote of thanks. Over to Dr. David.
Good evening to all. On behalf of ICA Pudukkottai, first I would like to thank our academic chairman, Dr. ALM, sir, for organizing 27th webinar, and thank you very much, sir. And special thanks to today's chairperson, Dr. Ramesh, sir, consultant pediatric anesthesiologist, Conch Pamakoti Child Trust Hospital, Chennai, for showing his excellency and experience in pediatric anesthesia. Thank you very much, sir. And also thanks today's speakers, Dr. Sanjina and Dr. Aswati, Dr. Jinan, for excellent academic session. And I also thank our president, Dr. Suresh Kumar, sir, and our secretary, Dr. Preishami, sir, and other faculties, postgraduate, for making this successful event. And thanks to Kirula and Aeologics for technical support. Thank you, sir. Thank you very much.
Shilpa, you can close the session.
Thank you, sir.
Thank you, sir. Bye, sir. Thank you.
Thank you.
Thank you so much.
Thank you all.